Welcome to Pedo Teeth Talk, brought to you by the American Academy of Pediatric Dentistry, a podcast show that delivers cutting-edge ideas for the professionals specializing in pediatric dentistry.
Thank you for tuning in to Pedo Teeth Talk. Today's show is brought to you by Elevate Oral Care, an innovator in preventive care. My name is Joel Berg from the University of Washington, and today I'm here with Jeremy Horst from the University of California, San Francisco. We're here to discuss today's topic of prevention, and specifically the use of silver diamine fluoride, or SDF. So Jeremy, I'm going to call you Jeremy, that will be first name here today, Jeremy.
Great.
I hear this SDF, silver diamine fluoride, we all are using it, and you hear it described as a game changer. Is it a game changer? And if that's true, why is that?
Well, it's good to hear from you, Joel. I'm glad to be here. I think SDF is a game changer for two reasons. One is that it's the first non-invasive treatment for cavities that are actually into the dentin that I believe we've had pretty much ever, besides silver nitrate, which disappeared somehow 60, 70 years ago. And the other reason is that we actually get incredible prevention on untreated surfaces. So by treating cavities, we get less cavities on other surfaces that weren't even touched by this material. And that gives us hope that we're actually finally starting to treat the actual disease.
So we're actually not just treating the results of dental caries, but we're treating the disease itself, which is something we've wanted to do for a long time. Is that right?
That's been the goal.
Yeah. So what actually happens? How does this silver diamine fluoride work?
Oh, that's a good question. So, the Cliff's Notes are that silver kills bacteria and fluoride strengthens the tooth, as we know. But the magic is that in reality, the fluoride actually kills the bacteria as well because it's such a high concentration. It's twice the concentration of fluoride varnish. And the silver also strengthens the tooth as well. And so, fluoride is really good at strengthening enamel, as we all learned along the last 5 decades. But silver, it turns out, is really good at strengthening dentin, especially demineralized dentin. It goes in, reacts with the proteins, and sort of forms a scab on the top. And as we've learned very, very recently, it actually condenses into solid wires in the dentinal tubules to kind of lay down rebar in the dentin, which is really cool.
Good way of putting it, rebar. I think, yeah. So it actually, I've read in the literature that the silver diamine fluoride treated demineralized dentin is actually harder than normal healthy dentin.
Exactly. And that correlates to the antimicrobial action. So I think the reason that really it works so well is that the silver and the fluoride incorporate into the tooth, and then the silver and the fluoride resist the bacterial invasion. So as the silver goes into the infected dentin, it kills the bacteria, and then it incorporates the tooth. So when bacteria try to grow back in, it comes back out of the tooth and kills them. So we jokingly called this the zombie effect. The dead bacteria come back to kill the living bacteria because the silver that's in there. But that's shown out in laboratory studies as well, where they take discs of dentin and try to grow bacteria on them, and bacteria normally can grow on dentin, especially strep mutans. If you treat healthy dentin with silver diamine fluoride, they don't like to grow back very well. But if you take caries dentin, artificial or otherwise, and then treat it with silver fluoride, it's actually even more resistant. So I think the magic is that we've really never had anything that would turn dentin into a slow release device to kill bacteria. And then, as you said, it hardens it as well, so it becomes a better substrate if we choose to put a filling or sealant on top of that. So
you said this earlier, but I think it's fair to say that what fluoride does for enamel, silver diamine fluoride does for dentin in terms of strengthening it and making it actually more resistant than the original material itself.
Absolutely. And there was a nice meta-analysis that was published early last year showing that the arresting effect of silver diamine fluoride in dentin is pretty much exactly the same as the arresting effect of fluoride varnish on enamel. So both about 2/3 according to that study. And then the group came back, the same research group from Hong Kong came back and did another meta-analysis later that year after they published a couple more trials and said, okay, well, we think it's maybe more like 80% arrest.
Well, I find it fascinating. I've been using the product for several years, and patients are asking about it, and it's getting out into the public domain beyond the professional domain. And are you seeing that as well? That patients are coming in and asking for this product?
Absolutely. I'm sure, like you, I've been shocked by patients traveling hundreds of miles to come see me, and it's been nice to see that die down a little bit because so many people, so many pediatric dentists have started to use it over the last year and a half since it's become available. So, 2 years ago when it first became available, I had people coming from Colorado and New Mexico to San Francisco to see me, and that's dried up. I do get those contacts still, but now I'm able to put them in touch with their local dentists who are using it.
Wow. Yeah, I'm seeing that same phenomenon. It's incredible how quickly, and I go back to my game changer term, how quickly this fire of silver diamine fluoride has spread. It wasn't widely used even a year ago, and dramatic exponential increase in use over the last year, and it's the most talked about topic, I would say. Would you agree in our profession right now?
Absolutely. I wish that I had good access to the adoption data for the high-speed handpiece, because that's what everybody says is, the benchmark for how quickly things got adopted. But talking to people, they say it took about 10 years to saturate the market, and I think we're somewhere around 7-8% by the end of last year of dentists that have a bottle, which is just amazing, a year and a half in.
That is amazing, and I expect it'll exponentially grow in the next years as well.
Yeah.
So speaking to that, what are some of in your mind, some of the top few indications for using very specific situations I'm talking about to use silver diamine fluoride? A couple of examples.
Yeah, well, I had the honor of leading a committee at UCSF to look over this material, and we actually put together direct indications because we wanted to keep things straight and keep everybody on the same page. And certainly severe or extreme caries risk. So if there's xerostomia going on, if the saliva is not working, and we know these patients are going to get cavities no matter what else we do, this is a great tool to pull out to curtail that process. And there's two really nice case reports, one from Peter Milgram at your nice institution, your fine institution, and one from Hong Kong showing that in these really severely affected post-cancer treatment patients that were getting rampant caries, just large lesions at every tooth, especially root surfaces. This stops it. It stops the process.
Yeah, that's the most aggressive progression one sees in dental caries in those patients, and the fact that this can halt it completely shows how impressive the effect is.
It's mind-boggling.
Yeah, it is impressive. So
as a pediatric dentist, I said, well, we see severe early childhood caries, and sure, sometimes that's, more than 5 lesions in a 5-year-old or more than 1 lesion in a 1-year-old and so on. But also it's, mouthfuls of caries, as you and I and probably all our listeners see. And we don't have good ways of really controlling that. We take them into sedation or general anesthesia, and they get new lesions back, within a year. And so this is one more tool to help treat that process where it's so easy to do. Just try and apply.
Yeah, it's fun to talk about, isn't it? When one is planning to use silver diamine fluoride, you see a patient and you have that situation, the 2.5-year-old primary first molar, large occlusal lesion, mushy dentin, the perfect case. Mm-hmm. But now you're going to talk to mom and dad about it. And of course, there's some anterior decay too. Now, obviously, we didn't mention yet that the stuff turns the tooth black. Not the tooth, but the diseased dentin black. Mm-hmm. So how do you go about talking about the use of the product and explaining, getting consent? Tell me a little bit about how you do that.
Yeah, well, I tell the parents that we have a new treatment for dental caries, for cavities, that we just brush on. And this has become our first approach to controlling the cavities. It turns the cavity black, jet black, but it leaves the healthy tooth structure its natural color. And then I'll point to the cavity on their child's tooth and say, you can see it's pretty brown or yellow or whatever the color is already. And so this area that's discolored will turn black. We can keep applying this over time and it increases its effect. And there's nothing here to stop us from doing a filling down the line if we decide that can be done.
So how do they respond when you say this? And do you show them pictures, by the way, in advance of what it's going to look like?
Every time. We always show pictures. So
we do too. I think it's a great, it's an important thing to do. Yeah, we show very specific ones, so there's no surprise.
Right. And I think showing before and after pictures is really important as well. So you can see, okay, this is what it looks like before. This is what, because there is a difference. It does turn much more significantly black, and people should expect that. And my experience is that in posterior teeth, I believe in this. And I think that probably has something to do with my the acceptance of the parents that I introduced it to. For posterior teeth, I have near complete acceptance. And for anterior teeth, it's dramatically lower. I would say, but maybe half of patients. That said, it's not rare for me to use silver diamine fluoride on a 1-year-old, a 2-year-old, and then I go and see the sibling. I might not even realize it's a sibling because, as we know, gets busy in a pediatric dental office, and sometimes the assistants don't alert me to that, and I didn't figure it out myself. And I'm talking about how we're going to approach the caries in this 4-year-old or 6-year-old who has great behavior, and then the parent will say, "Well, can't you just use that stuff you used on my 1-year-old?" And I say, "Well, sure, it's a front tooth." And say, "Yeah, these are baby teeth. They're going to fall out, right?"
Yeah.
And it's so, when I first started talking about this, and I think you probably had a similar experience, all the dentists, all of us dentists, including myself, said, "Whoa, we're going to turn the cavities black." And the parents kind of said, "Well, so what?"
Yeah, I often would describe the jet black effect as a way to indicate that it's effective, and that I like the fact that it's black because now I know it's working.
Yeah, exactly.
And then I tie that into the hardness, and I show them, how I'm testing the hardness of the dentin. And speaking of testing,
beautiful.
When do you have your patients back? So you treat them, that situation I just described, or any situation.
Yeah.
When are you going to get them back for the next check?
Well, let's go with the situation that you described, where there's nice mushy dentin, the stuff the stuff of nightmares, and my protocol has become to treat them at the diagnostic visit. So if they're there, patient's in the chair, patient gets treated with silver fluoride. And then I'll have them back 2 weeks later where the RDA will treat them, those same teeth, usually the one that was chairside with me the day of the diagnostic visit. And they come and go, and I don't, I'm of course there, but I don't even see the patient. And then 2 weeks later, I'll come and evaluate the outcome. So, the protocol that we suggested from UCSF was twice a year or more frequently, depending on caries risk, because that's what had been done at the time. That was the most frequency that had been shown in any clinical trial that was monitored, so we knew it was safe,
right,
and that there was a more effectiveness. But 2 years later, now there's been other clinical trials that show that there's a little bit more effectiveness in doing 3 times in a short amount of time. So that's what I've started doing, and it's confusing. It's we've never really had this situation before. I think I've shared my little bar charts with you, and it shows really clearly that if you just apply once, at 6 months, about 40% of cavities are stopped. And then if you keep applying every 6 months, by 2 years, 90% of cavities are stopped. But how do we know which is going to be that 10% and which is going to be the 90%? And that's hard. And so, one of the things that we've learned as a community of early adopters like yourself is to not throw any tool away. Everything that we've learned as pediatric dentists stays in the tool belt. So this changes everything, but we don't lose anything. We still have all of our techniques. And so
that's right. Yeah.
For the big, hairy, cavitated, plaque trap, food trap lesions, a lot of us have started combining with ART, or as AAPD likes to call the ITR technique. And what we find is, just less scooping is necessary, less excavation is necessary.
Right. I'm finding that as well. I find it works better when I don't excavate because I'm rinsing it out at the end of the application. The mushy dentin acts as a reservoir, so you get a little bit extra retention. It's kind of like what you said before about the dead bacteria, as being zombies for the living ones, right?
Yeah. Have you been combining with glass ionomer?
I do that in some cases, and some of my colleagues will do that with immediately, and even doing anterior sort of crown formers with resin modified glass ionomer, after applying. one of my colleagues, Travis Nelson, who you know, he does a lot of those. He's had great success with the strip crowns, so to speak, with resin-modified glass ionomer.
Totally.
So I think there are options, and I think, as you said, that it's early, so so much more is going to come.
So much. I'd like to add on that just that what we've seen over time, because some of us have been doing this, like you said, for a few years now, and I've done this with composite, with resin-modified glass ionomer, and with pure glass ionomer, and for better or worse, what we've found is that if there's any plastic, any composite in the filling, that over time, and sometimes it's as long as a year, the stain will come, that it'll actually turn that whole beautiful white composite or resin-modified glass ionomer pretty dark gray over time. Mm-hmm. And whereas the pure glass ionomer stays white, but the margins turn black. So it almost looks like a refaced stainless steel crown.
Yes. But I think we're early in the game, and I suspect people are working on solutions, and we'll have some. But
hopefully, there's a lot of opportunity there. But I just wanted to finish that, Joel, by just saying that my technique has been pretty foolproof. Of just, if I want the restoration to be aesthetic, I do not apply silver diamine fluoride and the restoration on the same day. And that's worked really. I'm sure you've probably done that.
I rarely apply them on the same day, and I just tell. And one of the other reasons I don't apply them on the same day is what I alluded to earlier, that I want to see that black and be able to feel the hard dentin. So to separate the treatment of the biofilm from the restoration of the tooth is conceptually two different things.
Yeah, and you can do this during the diagnostic visit, and I think it would be a bigger consideration to try to do atraumatic restorative treatment during diagnostic visit. That's just it's a lot more.
Yeah. So. This is fantastic. So I wanted to ask you, Jeremy, silver diamine fluoride is this game changer product, and I think it comes to place in the midst of a lot of discovery in the area of biofilms. It's a big interest of mine and yours. Mm-hmm. And I think, wouldn't you say that there are going to be many other products like silver diamine fluoride, but not silver diamine fluoride, that will also be in this category of medical management of caries?
I think you're absolutely right. So that's what I've been spending the last 4 years of my life on, and during residency, that was my research life. So it's been, 7 years now, where I've been trying to find better treatments for dental caries. And let's just say I've used some pretty advanced technology and some pretty rudimentary technology, as in looking through the literature of the last 100 years on caries and distilling it down. What I can say is that the things that we really have are ions. We have fluoride ions and we have metal ions, and if you look down in the periodic table, what you get is metal ions and then fluoride. Okay, well, iodine seems to work as well. Oh, same column in the table. Yep. And so I think, what we can be sure of is that we're probably going to see more metal or halide-based treatments coming out. And that seems to be the magic combination. And I think we'll probably be, I hope that we get some actual sort of organic medicines, but I don't see that happening anytime soon. But a lot of us have kind of slept on stannous fluoride. If you actually have compliance, stannous fluoride can do pretty well.
Well, metal, as you said, metal ions, right?
Metal, and fluoride.
Yeah.
And that ions. Said, there's exactly, and there's also nano silver, and so there's been, as you know, a clinical trial showing that silver nanoparticles with shrimp shells, chitosan, works to stop cavities. And they didn't compare it to silver diamine fluoride, which was unfortunate, but they did show that it worked compared to placebo. And so I know there's some movement there where the idea is to get the concentration of silver down, but keep the effectiveness, and if you get less silver in there, then we won't have stain. And so there's a lot of interest in that, and I imagine that in 5 to 10 years, if the FDA is kind, they'll let that come through.
So what do you know about this product that's not available in the U.S. that talks about adding a potassium iodide, another ions again, and you mentioned iodine, and I think it doesn't have approval in the U.S. There's conflicting information regarding does it mitigate the effect of the silver diamine fluoride when you apply the potassium iodide?
Yeah.
Can you tell me about that?
Joel, thank you for bringing that up. I actually had the honor of meeting the inventor of that just 2 weeks ago. I met him
myself. Yeah,
Graham Craig, nice guy. Mm-hmm. And this was really intended to be under restorations,
right?
Because what he knew is what I found by accident, embarrassingly, is that If you leave it exposed, so if you leave it exposed, the stain comes more slowly, but it comes. And so what does that mean? So the idea there is that you dry and apply silver diamine fluoride, and then you apply a saturated solution of potassium iodide, which we can get in this country. We can't get the dental product, but you can get from a compounding pharmacy, Lugol's solution or SSKI. And you keep applying it until you don't see any new precipitates form. And then you rinse it off and go about your business. And the idea is that you get silver iodide precipitates, and those precipitates are whitish or yellowish white. And so it just doesn't, it's not black. And so, when you leave that day, if you have the patient come back a week later, where normally a silver diamine fluoride treated cavity would be black, this is not black.
Right.
The problem is if you have the patient come back a month or 6 weeks later, it is black. And so the intention of this product was really to go under a glass ionomer or something that seals it. And so that said, I thought that it was working so well when I first started using it. When I was back in the days of silver nitrate. I got all excited about it and started using it and started putting it under composite restorations. And a month later, everything was black. So one of the things that this taught me was that, flowable and composites really don't stay sealed.
Right. That's right. Well, hydrophobic materials in a hydrophilic environment. So it's very challenging. It's the holy grail to find something that's hydrophilic but also stays in the tooth and doesn't break down. Yeah, it's tough.
Yeah, exactly.
Yeah, wow, it's interesting. So I have one last question for you. You mentioned 7% have the bottle, which is gigantic, it
really is.
For a short period of time. Mm-hmm. What would you say to the other dentists who don't have a silver diamine fluoride regarding why they should think about it in their practice?
Yeah, we all have patients and lesions that are hard to treat and frustrating situations where caries keep coming back. I would recommend getting a bottle or borrowing a few drops from a friend and keeping it in a nice plastic container that's to have for those patients. I started this process myself with a child who had already undergone general anesthesia for dental treatment. He had 12 teeth treated then. All 8 composite restorations failed, and he had 9 new lesions by the time I met him. He was so medically fragile that the pediatric anesthesiologist refused to consider bringing him back to the hospital. The mother refused. The kid had almost died under anesthesia for other purposes. And so I brought out this silver diamine fluoride from Japan. This is, 4 or 5 years ago, and gave it a try. And, along my path, I started with those kind of extreme cases where we really didn't have anything that worked. I didn't have any other good options. And in my hands, I saw it work so well that I started asking myself, don't normal children deserve this too? Mm-hmm. As good as we can be, we still have children struggle in the chair. We still have difficult, starts to sedation or sedations or anesthesias or normal procedures. It's tough what we do. And so this is just something that will help us out, both in our management of the disease and in our relationships to the families that we serve.
Fantastic. I couldn't have said it better. I tell you what, Jeremy, every time I talk to you, I learn so much. I appreciate
Likewise, Joel.
Appreciate talking with you today. And I have to mention that you and I, to everybody in the audience who's hearing this, that we're going to be talking together at the annual session in D.C. end of next month. So that I'm looking forward to that.
I'm really looking forward to that, Joel. I think it'll be a real good opportunity to hear back from the community as well. In these sessions, I'm sure I'll learn a ton from you. You've been generous to share your slides, and I go through them probably once a month for the last year that you sent it to me, and I learn something every time I look at it. And, the community of pediatric dentists have such great questions and such great points.
We have a great community.
We do.
It's the best there is. Well, thank you, Jeremy, for being with me on Pedo Teeth Talk. I'm Joel Berg, and I thank our sponsor, Elevate Oral Care. And finally, a very big thank you to you, the listener, for tuning into the show today. Thank you very much.
Thank you.
Pedo Teeth Talk is brought to you by the American Academy of Pediatric Dentistry, the show that delivers cutting-edge ideas for the professional specializing in pediatric dentistry. If you have any questions or comments, please email info@aapd.org. We welcome your ideas for future shows and guests. For more information on the American Academy of Pediatric Dentistry, visit aapd.org. pediatricdentistry.org.